Risk factors for atherosclerosis. These risk factors have roughly a multiplicative effects. This means that if the patient has two risk factors, the risk will be increased for myocardial infarction or other manifestations of atherosclerosis approximately by fourfolds. If the patient has three risk factors like hyperlipidemia, hypertension, and smoking, then the risk will be increased by a rate of 7. Risk factors are classified into major constitutional non-modifiable risk factors and major modifiable risk factors. The major unmodifiable risk factors includes mainly age, gender, and the family history or genetics. The first major constitutional non-modifiable risk factor is genetics. Family history is the most important independent risk factor for atherosclerosis. It's related to multifactorial traits, including hypertension and diabetes. But less commonly, certain Mendelian disorders strongly associated with atherosclerosis, like familial hypercholesterolemia. So, familial hypercholesterolemia is considered constitutional non-modifiable risk factor. The second major constitutional non-modifiable risk factor is the patient's age. Since atherosclerosis usually remains clinically silent, which means asymptomatic, or there is no manifestation of the presence of atherosclerotic plaque until lesions reach certain critical threshold. This happens usually in the middle age or later. So most of patients presents with manifestations of atherosclerosis between the age of 40 and 60. And at that age, the incidence of myocardial infarction increases fivefolds. The threats too from ischemic heart disease continue to increase with each successive decade. Gender is another constitutional non-modifiable risk factor. Since premenopausal women are relatively protected against atherosclerosis if you compare them with age-matched men with all other factors being equal. Myocardial infarction, for example, and other complications of atherosclerosis are considered uncommon in premenopausal women in the absence of other predisposing factors like diabetes, hyperlipidemia, and severe hypertension. However, after menopause, the incidence of atherosclerosis related diseases increases and can even exceed the incidence in men. So, does that relate to the presence of estrogen in the reproductive age? Clinical trials have shown no benefit of hormonal therapy for the prevention of vascular diseases. So, even after menopause, if you give ladies a hormone replacement therapy to replace the estrogen that is lost after menopause, this have no benefit to prevent the vascular diseases. So, the estrogen replacement after the age of 65 also can increase the risk of cardiovascular diseases. Gender also can influence other factors that can affect the outcome in patients with ischemic heart disease, like hemostasis, infarct healing, and myocardial remodeling. Modifiable risk factors, on the other hand, are those risk factors that can be modified by the patient through lifestyle modifications or medications. The first one is hyperlipidemia. Hypercholesterolemia is a major risk factor for the development of atherosclerosis, and it's sufficient to induce lesions even in the absence of all other risk factors. The low density lipoprotein, which is the LDL cholesterol, and as we call it, the bad cholesterol, delivers the cholesterol to the peripheral tissue. So it starts storing the cholesterol in the peripheral tissues. While the high density lipoprotein, the HDL, which we call the good cholesterol, it's called good because it starts mobilizing the cholesterol from the atheromas and transport it to the liver to be excreted in the bile. So higher levels of HDL and lower levels of LDL correlate with reduced risk of atherosclerosis. For example, the high dietary intake of cholesterol and saturated fat, as those present in the animal fat butter, for example, raises the plasma cholesterol levels, and this associates with increased risk of atherosclerosis. On the other hand, Diets that are low in cholesterol or higher ratios of polyunsaturated fats, those diets lower the plasma cholesterol levels. Omega 3 fatty acid, which is abundant in the fish oils, are beneficial to lower the cholesterol. So, hyperlipidemia, as one of the modifiable risk factors, can be modified actually by lifestyle modifications and diet change, elevating the HDL in your diet, lowering down the LDL and cholesterol in your diet, start exercising, and you may add statins, which is one of the widely used drugs that acts on lowering the circulating cholesterol levels. The second modifiable risk factor is hypertension, and both systolic and diastolic levels are important. And this increases the risk for ischemic heart disease by 60%. So that's why we need to control hypertension. And it's considered also a major cause of left ventricular hypertrophy. So we consider this factor as a modifiable risk factor because lifestyle modification, start exercising, and also medications can control this risk factor. Cigarette smoking is another modifiable risk factor because prolonged smoking of one or more pack daily doubles the rate of ischemic heart diseases related mortalities. So smoking cessation reduces the risk. Diabetes is another modifiable risk factor for atherosclerosis because it's associated with raised circulating cholesterol levels. The incidence of myocardial infarction in diabetic patients is twice as in non-diabetic individuals, with other risk factors being equal. Diabetes mellitus is also associated with increased risk of strokes and 100-fold increase in atherosclerosis-related gangrene of lower extremities. Besides the major risk factors, which are, as I said, classified into modifiable and non-modifiable risk factors, we have minor risk factors that play a role in the development of atherosclerosis, one of which is inflammation. As we all know, inflammatory cells are an important player in all stages of atheromatous plaque formation. So they are closely related to the plaque progression and rupture. يعني تكون البلاك في كل مراحلها بده يكون فيه inflammatory cells. The inflammation has certain systemic markers which we can detect by drawing blood and examining this blood for those markers, like C-reactive protein, for example, which we consider as a sensitive marker for inflammation. It's of interest that the CRP or C-reactive protein is reduced by smoking cessation, weight loss, and exercise. Another minor risk factor for atherosclerosis is the hyperhomocystinemia. Hyperhomocystinemia means that there is an elevation in the circulating homocysteine, and the serum homocysteine level correlates with the coronary atherosclerosis, the peripheral vascular diseases, stroke, and venous thrombosis. يعني العلاقة طردية. كل ما زاد السيرم homocysteine level, this will correlate with the increased risk of atherosclerosis and other vascular diseases. Homocystinuria. Homocystinuria means that the patient have a rare inborn error in metabolism, causes elevated circulating homocysteine level, and this is associated also with early onset of vascular diseases. Another minor risk factor is the metabolic syndrome. Patients who have metabolic syndrome, they have usually or suffer from central obesity، يعني بيكون فيهم نصاحة تتركز في منتصف الجسم، insulin resistance, hypertension, dyslipidemia, hypercoagulability, and a pro-inflammatory state. And all this mixture will increase the risk for sure for atherosclerosis.